Good afternoon, everyone. Can you guys hear me? Okay. So, as Dr. Madrick mentioned, I'm one of the kidney doctors at Stanford, and I have a particular interest in chronic diseases and global health. And the title of my talk today is somewhat broader than what's listed on your pamphlet, but my overall goal is to discuss the state of women's health in developing regions within the context of a change in the patterns of diseases that these regions are facing. The first goal actually is to convince you that a nephrologist or a kidney doctor can have a viable interest in global health. And so I'm going to show you, to do that, I'm going to show you some data looking at the biggest causes of death in developing regions. And you'll see that it's no longer just episodic and infectious diseases like respiratory tract infections or diarrhea, but also diseases that span a life course and include things like diabetes, hypertension, cardiovascular disease, and kidney disease. And then in the second part of the talk, I'll offer some hypotheses about why I think women may have some unique vulnerabilities as this transition in the types of diseases is occurring in the developing region. So I think the global health community first widely recognized that that chronic diseases were important in 2005 when the World Health Organization as well as the Lancet Medical Journal published a series of articles indicating that most of the deaths due to chronic diseases are actually occurring in developing regions now, and that these deaths tend to be premature, meaning that patients with chronic diseases dying in developing regions tend to be younger on average than patients with the same diseases dying in developed regions. And there was a lot of activism around this issue to the extent that there was actually a UN Health Summit in 2011 where Secretary General Ban Ki-moon made strong statements about how chronic diseases should be on the development agenda across the globe. And I do want to show you some hard numbers backing some of these statements. So this is data from the World Health Organization from 2011. And as you can see, in all regions except in Africa, chronic diseases or non-communicable diseases, which are labeled in green here, were the #1 cause of death for both men and women. And even in low-income countries, of which Africa is a major part of this category, the projections are that by 2030, chronic diseases like stroke or ischemic heart disease will be the major burden of disease in these countries as well. So you might say, okay, so the patterns of diseases that these countries are facing is changing, so what does that mean? I think for overall health, what I think the global health community has recognized that this means is that we need to move away from what we call disease silos, so move away from having a HIV clinic or a TB hospital, so specialty hospitals that just take care of episodic illnesses, to hospitals and clinics that incorporate health, lifespan health. And I think that's something that we're struggling with in the developed regions as well. It's not something new, but I think the context is different in that you have to do that with lower resources, obviously. But for women's health, I think the unique implications are. There are some unique implications that I'll talk to you about in a little bit more detail, but I wanted to sort of lay out a little bit of a framework for some of the hypotheses that I have about why women's health would be differentially impacted. And this framework is something that's widely used in women's health, and it incorporates both gender and sex. So on one end of the spectrum is sex, which is the biologic predisposition or the biologic nature of being a woman. And there are some conditions that are linked uniquely to that, like reproductive health or breast cancer or cervical cancer. But then there's, on the other end of the spectrum, are diseases that are linked to gender or the cultural norms associated with being a woman. And these are things like sexual and domestic abuse, which are generally by far, women are more impacted by these diseases or conditions than men. But the diseases that I'm going to be talking about, or the risk factors that I'm going to be talking about, they lie sort of at the intersection of sex and gender. And I guess the point that I want to make with this framework is that women do have some biologic predisposition to some of these risk factors, but gender or the cultural norms associated with being a woman also play an important role here. So one example for why, what I mean is that we know across the world that women tend to be more obese. Women just tend to be more obese than men. And you could say that that's partially biologic, because we know that women tend to also have a greater percentage of fat in their body than men. But then when you look at sub-Saharan Africa, for example, or look at the Middle Eastern countries, you see that the difference between men and women in terms of obesity prevalence is much more marked, much more striking in these regions. And when a couple of economists from Princeton and University of Chicago actually looked at this issue, so these were economists, so they did a different analysis than other folks, but they wanted to look at what could explain the difference in obesity rates. And what they found was that the major driver was actually, so they went and surveyed about 500 households in Kailicha, which is one of the largest shanty towns in South Africa. And what they found was that women tended to be more obese when they were on the upper status of wealth within this context of this shanty town. So not overall in Cape Town, but within this small spectrum of income, if you were on the higher tertiles, you tended to be more obese. And in this shanty town, your body size actually was captured by what was actually reflecting your wealth. So the bigger you were, actually, the more wealthy you were perceived to be, and actually more healthier too, more healthy. And then also women reported, women who were more obese also reported more childhood hunger. So both of those things, they felt that explained the prevalence difference in obesity. So again, these are sort of, I just want to point out that these are cultural norms that are driving some of these risk factors that we're observing, and that these risk factors are having an impact. You know, the Lancet actually published a recent meta-analysis where they showed that maternal obesity is now a important driver for neonatal death in sub-Saharan Africa. So we know that here in the US, that an obese woman is likely to have a poor outcome with pregnancy, but this is something that is emerging as a risk factor even in sub-Saharan Africa at this point. Other things we know about, other things we don't know, but we're looking into for some of the traditional risk factors associated with chronic diseases is physical activity. And this is work that I did in collaboration with with several colleagues, but the work was led by Julianne Saqib. And this is a small survey in a middle-income neighborhood of Dhaka in Bangladesh, where Julianne asked women what their usual physical activity was. And about a third of them reported no walking at all, so they did not walk at all during the day. About half of them indicated that they walked less than 30 minutes in the whole day. And they were more likely to they spent more hours watching TV. They were more likely to use a car to just go less than a kilometer. And across the board, they reported more barriers to physical activity than men. So this is something that I think maybe specific to some societies where women are more confined to the home and safety is an issue, but then also they reported just lack of skill and lack of family support as an issue for going out to have even walking as a physical activity, which is a known risk factor for many chronic diseases. But then there are also some risk factors that women face that we don't know as much about. So household air pollution or indoor air pollution is something that is emerging as a risk factor for many chronic diseases. And this is a photo of a woman cooking in a rural area in Peru. And this is a cook stove that they use to cook, and it generates a lot, we know it generates a lot of indoor pollution. And women and children are more exposed than men, and exposed women are twice as likely to have lung disease, which makes intuitive sense. But there's also emerging data that there is a link between air pollution and cardiovascular disease and stroke. And we don't know as much about that. And so that not knowing about what what risk factors our women are facing makes it harder for us to sort of treat or prevent a chronic disease. Oh, sorry. And so another risk factor that we can talk about is chewing tobacco, which is sort of a cultural practice in South Asia and Southeast Asia. And this is data from a World Health Organization survey in Cambodia, where they found that a majority of men were smoking cigarettes, and the majority of tobacco use in women came from chewing tobacco, from chewing the betel nut leaf. And again, this is something that was culturally engendered. When they asked these women, why are you chewing tobacco? They said, well, some of them chewed it at the time of pregnancy. So it was sort of a rite of passage for them. When they became pregnant, they were told, you can now chew tobacco. And it'll help your morning sickness, and it'll help reduce your nausea. But we know that chewing tobacco will increase your risk of mouth cancer, but there's emerging data that it may increase your risk for all kinds of cancers, and we don't know the risks for cardiovascular disease related to chewing tobacco. So we have less knowledge about some of the risk factors that we see in women. And then lastly, I also wanted to talk to you a little bit about why once a woman develops a disease, why she would be uniquely vulnerable to having some adverse risk factor, adverse sort of outcomes related to the disease. So women are much more likely to be depressed than men. And we know this from lots of data, including the Global Burden of Disease study, where it shows that women are nearly twice as likely across all age spans to be depressed. And we know that depression is associated with worse outcomes. So survival among patients who have depression and cardiovascular disease, which is shown on the first figure here, is much poorer. That's the small dashed lines. And it's the same, like the number, if you look at it in another way, the number of deaths is higher if you're depressed. And so the confluence of depression and a chronic disease will be higher in women probably, and will put them at risk for more adverse outcomes. And so then the question comes, why do you think women would be more depressed? And partly it could be biologic, especially if you think about postnatal depression, which we feel is related to hormonal influences. But then when the World Health Organization looked at this issue, they posited that a lot of these factors, a lot of cultural factors, were actually the reason that women were more likely to be depressed. Women tend to be poorer. 70% of the world's poor are women. Women don't have income inequality. Women have a subordinate status in their household and in the society, and they presume a caretaker role where they put their own health sort of on the back burner. And in fact, what we know helps people cope with stressful situations is if they feel empowered in that situation, if they feel like they have enough emotional and financial strength to influence the outcome of that situation. And women, as you can probably intuitively guess, in developing regions are less likely to have that power and empowerment than men. So that's some of my hypothesis about why we would have to think a little bit more closely about women's health in a context of the framework that we've used to look at women's health in the past, and sort of apply it to this transition where developing regions are facing more of a chronic disease epidemic and more of more of a focus on taking care of the person across a lifespan. But I wanted to end on a positive note, because I recently went to DC for a talk where we talked about task shifting as a way of providing primary care, so asking community health workers to be involved in primary care. And what a lot of these regions we're finding, especially for example, in Mexico, they described that when they went out in the community to recruit community health workers, women were by far the largest group of volunteers. They got like, in one village, they got 7 women and 1 man, and they had to like recruit men to actually help reach out to men. So I think if we are using more innovative ways of taking care of primary care types of issues in developing regions, we may be more likely to be involving women, which will help care for women and care for their health in hopefully a better way. All right, thanks.